analysis. It's really just dipping your toes into lean. And some of you, we presented on this topic last year. And so if you were at that one, there's going to be some repeat, but there's a lot of new stuff in here too. So we really are thinking about this. This is part of a 2-part series on lean we're doing. There's part 2 will be next month. And this is dipping your toes in the water. So if you have your basic understanding of QI and don't really know how lean could be used with some of the tools and knowledge you already have, that's what we're going to cover today. And then the part 2 will take it to a more, I think today is a more intermediate level, and then next month will be a more advanced level. So thank you all again for joining. If you haven't put your name, location, and agency in the chat, please go ahead and do so. And I will go ahead and pull up the slides. All right, you can all see those. Okay. So my name is Justin Britannic, and I'm a coach for CQII. And today I get to do my favorite thing in the whole wide world, which is talking about quality and specifically about lean. And for those of you that may not really know a lot about lean, you don't have much of a background, we're going to approach some of the concepts, actually really focusing on one of the concepts behind it today, and just kind of getting started. How can we take some of the tools we might be familiar with and apply some lean concepts? So our learning objectives for today's session is, by the end of the session, I hope you're able to say, I understand the difference between process and flow. I know how to map a process. I know how to use a process map, and not just to have a pretty diagram of our process. How can we use that for some improvement? And thinking about incorporating lean concepts, specifically flow, into your quality improvement work and CQM program. So any questions? Is anyone here like, this is expecting anything else? All right, this looks pretty good to get started. All right. So as I go along, feel free, we have a lot of time. So feel free to interrupt, ask questions, raise your hand, use the chat. I'll try my best to keep an eye on the chat. I know Shay will help me out if I miss anything. Okay, so starting at the beginning, process and flow. These are English words. These aren't weird quality improvement words. They're Japanese or anything like that. So I know them. So what do they mean in QI? That's the first thing I want to cover today. So process. And can I just get a volunteer either in the chat or take yourself off mute and say, what is a process? How would you define a process?
A systematic way to get an outcome.
A systematic way to get an outcome. Great.
Anika said steps to make something happen.
Something happen. Great. Perfect. So, I mean, between those two definitions, you covered it, right? A series of actions or steps taken to transform inputs to achieve a particular end, a goal, an outcome. So we're kind of starting here with all these loose gears that aren't the same shape, they don't match up. We're using some ideas, we're putting them together, and we're ending up here with some gears that turn. So, I mean, everything is process. You can literally take anything you do, whether it's the way you get ready for bed, the way you answer your email, the way you serve patients, the way you write reports, all of that is process. And I have a little example here of making coffee. And I love making coffee because there's no one right way to do that process. We all have different definitions of what the outcome should be. Some people want to run to the gas station and get something quick. Other folks may have something a little bit more in depth, like this here process for making pour over coffee. But I think the important thing to keep in mind is that process is really the root of quality improvement. We're not improving measures. We're not improving interventions. That we're starting with a process and we're measuring it to improve it. We're adding interventions to change the process. So really, until we understand process, we don't want to jump right to solutions. So it's important that we understand the process and any problems within. And I like this little example of the pour over coffee because it has some, the steps we kind of see, there's decision points, some loops here, but it highlights some things. We have some measurement in here. So measuring out beans, we have some, thinking about that voice of the customer or, the patient or client, and that, do they want milk? Well, then we need to make sure if they want milk, that's included in our process. Do they want sugar? Yes or no? You gotta make sure that's included in our process. And I think the other thing I want to kind of put here is, we could buy the most expensive, fancy, coffee beans from the top of an Ethiopian mountain. But if we're not following the process, we're not measuring out the water correctly, we're not boiling it to the right temperature, we don't have the right technique when we make the coffee, we're going to spend a lot of money on coffee beans, but that coffee is not going to be as delicious as it could be as if we follow the process. So the first thing we need to understand about process is, in a context of an improvement project, they're evolving. That our process starts out as something and we want to get to somewhere else. So that goal. And the states are the current state. So that's where we start in our process, the way things actually are today at the beginning of an improvement activity. And then we jump all the way to the end. We say we're going from the way things are, the way we document them today, to how could they work in a reasonably perfect world? What could this process look like? So we're not going to map it that, if we had $1 million and a new EMR tomorrow, right? We're going to say reasonably. If we could just redesign this, what would it look like? And then the next state, once we've gone from the way things are, the way they could work if everything was right, to the improved state. Once we've done a test of change, and we think about the PDSA cycle as iterative, that we're doing multiple cycles that are building on each other. What does this process look like after one cycle? What does it look like after two? And then the future state is really, where do we get from one improvement cycle to the next? So in the next 1 to 3 months, how do we get a little bit closer to this number 2 ideal state? Is that pretty clear? So we go current, ideal, improved, future. So how do we map these processes? Well, there are a lot of tools. And in different contexts, it'll kind of choose what tool you want. So sometimes for things that are already well established and maybe you have some policies around, you might do a procedure list. So that's going to be more of a bullet point listing of the process. If you're working through a physical space and you want to minimize motion and transportation, then we're thinking about a spaghetti diagram. Swim lane maps are really helpful to visualize handoffs and bridging silos in a process. Decision trees, a lot of times you see those in research, that if this happens, we're going to do that. But today I want to focus on 2 ways to map a process. So a flowchart, which is probably what folks are most familiar with. If you say, map a process, flowchart is probably the first thing we learn. And these are super powerful tools that I think are underutilized. And I hope to show you some new ways to apply them today. And the next one, this is might be something new. So Gemba walk, it's kind of a funny word, but it's really, this is more not an actual process map format. This is a strategy we use to map a process. And then in part 2, we're going to be covering value stream maps. So that's, again, another way to look at process from just the steps that are happening, but how do we perceive the value is? And we'll build on top of what we cover today to get to that. That's really a little bit more advanced. So why do we map a process? Well, a picture is worth 1,000 words. And so on the right-hand side of this slide, I have some of like the defining moments in royalty-free photos. And you just taking a look at them. Someone mind taking themselves off mute or putting in the chat and saying, what can you see from this photo? Just what words come to mind? What is being conveyed? Pick one that speaks to you.
Success.
Success for which one?
I see that for all 3 pictures.
Yeah,
that's what they have.
Really a theme there. Yeah, sure. So triumph, winning a gold medal and also speaking truth to power, showing solidarity, landing on top of the moon, something that we thought could be impossible, or the flag at Iwo Jima kind of triumph. And so that's exactly. And so we don't have to write a paragraph and say exactly what was going on here in the history, just seeing the picture, just kind of using our own expertise of what maybe a little bit we know about these historic events gives us a really powerful understanding. And a process map is the same way. It's distilling a lot of details, a lot of action, a lot of what different folks are doing, and it's giving us one visual that we can all huddle around and make some sense of for improvement. It gives us all a clear understanding of what we're working on. And I think it's a foundational tool for our quality improvement. So the first start we want to think about is when we're mapping a process, where do we start? And I think this is, where I see quality improvements projects go off the rails already, is right in the beginning, is picking that process and having defined starting and endpoints to that process. So I always encourage people to start, start with one patient, one function, one facility, that you want to start thinking about one thing that's typical that you do every day and map that out. So in a brainstorm, that might be what triggers the process, and end with a value creation, end with our customer, our patient, our client, our staff, our internal customers getting something. Something is happening, something is being achieved. And we'll talk a little bit, we're not going to have time to cover it today, but the tool of a SIPOC diagram. So that stands for stakeholders, inputs, process, outputs, and customers. And so I think everything that fits on that diagram is what you want to fit in your process. So start by, keeping it high level, maybe 6, 10, 12 steps. Like, that's a good place to start, and then filling in some of the detail. Always start with typical processes. That's where you will find typical ways. So don't map something that only happens once in a blue moon. We want to map things that happen routinely so we can find those routine problems to solve. And so once we know, what we're going to map, that started endpoints of that process, the next thing I want to turn our attention to is this concept of flow. And flow is another common word. So would someone mind giving me their plain language definition of flow?
Moving through the process.
Moving through the process. Great. Absolutely. So it's the movement of people, materials, and information through a process or system, which is just several processes connected towards accomplishment of a goal. There are really two kinds. So the concept of flow, this really comes from manufacturing before it was in service delivery and healthcare. It also has a background in psychology, this idea of that there's this highly focused mental state where we're super productive, we're in the zone, we're going with the flow, so to speak, and that we're doing what we need to do without being overly focused. And flow in service delivery is the exact same way. So you can have good flow, you can have bad flow. Continuous flow is what we think of when we talk about efficient, value-driven process, that the flow is continuous, that everyone is kind of in that state, in that zone. We know what we're doing now, we know what we need to do next, and we're ready to do that. Interrupted flow is what we say when a process or product has to wait for the next step or wait for the material, that there's delays, there's rework, there's loops, there's complexities. That's what we think of interrupted flow. And using lean improvement methodology, the goal is to move from interrupted flow to continuous flow. So think of our process like a stream going through a forest, and there's rocks and fallen trees, and that's stopping the water. That stream could get dammed up, and then it could flood and all kinds of things. So our service delivery is actually quite the same. So here's a super basic diagram. We're going to get more complex in these diagrams as we move throughout our time together this afternoon. And it kind of starts as a client walks in the door, they do a little waiting, the receptionist makes copies, intake, interview, client sits in the room for 20 minutes. So seeing this, would you say this is uninterrupted flow or interrupted flow or continuous flow?
It's interrupted.
Interrupted.
Yeah, absolutely. This is interrupted. That we have these questions of why. Why is the receptionist making copies instead of addressing the client right away? Why is the client waiting in the room for 20 minutes? I mean, there may be a good reason, but it's something that we could potentially improve upon. So this is really simple, really hypothetical, but it's also realistic. I mean, this happens every day. I worked in a clinic for a while back, and I remember like this is pretty realistic. And so the completion of the process, the goal for what's going to create value for that client is being able to meet with their doctor. That's what they came to do. And so there are other steps in the process. We may have backups, bottlenecks, and these are the things that using a lean methodology we want to address. So the next couple concepts related to flow are push and pull. And push in the manufacturing lean world, it kind of means to make and to put into stock. So we're just pushing these out. And we can think of it with patients too and clients that we're kind of pushing them through the door. Get your food bank, get in, get out. And they're working around our schedule instead of us working around their schedule. So some examples here in food bank home delivery meals, it could be building up a supply of ingredients to get better deals. And then we might have some of these ingredients go bad. We may be taking up our storage room with tons of stuff. We may buy a ton of canned beans and then find out all our customers don't like beans and want less of them in their food bag, right? And then so we have all these beans we don't know what to do with. It could be in clinical services, patients waiting for a physician that isn't ready to see them, that we're just taking them from the front desk and just get them out of that waiting room, get them on to the next, and then they're just sitting in another an exam room. So we're just pushing them from one place to another. So I mean, these happens for a lot of reasons, and just that we're not really good at predicting, what a potential day will look like. Especially, I think of in clinical services, we have our schedule set. We have a provider who's going to see X amount of slots a day, and it doesn't matter if 10 patients come or 50 patients come. That we know who's on the schedule, who's scheduled, but there's all these things that happen throughout a day that throw that schedule off. And then so the opposite of that is pull. And pull is really thinking system-wide and not just getting a patient or client through one part of the service to the next. It's really thinking system-wide. It means doing things just in time. Just as I need to see that patient as I'm finishing with one patient, the next one's showing up. So it really requires a lot of planning. It requires some analysis. It's triggered by demand and not supply. It's how many patients need a service today instead of how many slots that we have. So a few examples of pull would be in a home delivered meal provider. Meals are prepared, packed, and staged for delivery, and delivered without any defects, waiting, or bottlenecks. So there's the diabetic meal over here and the low salt meal and they both need to go on the same truck. We're not waiting for one recipe to be done to start the next one. In a clinic, it could be the patient goes right from door to exam room. Provider's there as soon as the MA finishes, gets those vitals out the door, and then the door swings back open, the provider comes. So maybe not realistic, but that is what the goal would be. And just to kind of show you, I love this little example. It's kind of a silly commercial, but you can kind of see this would be pull at a lunch rush at a deli. So you see just everything's just, and this is a silly exaggerated example, but you kind of see how everyone is getting everything just as they need it. There's no waiting, there's no backup. And so I'll save you from watching the rest of it. Eventually there's something that happens that stops up the flow, but it's kind of, it's a good advertisement. So thinking about flow and push and pull, and the next concept we're going to add on to that is the idea of waste. And so waste is easiest to identify when we think of steps connected together in processes and processes connected in systems. So this little example here, if we're not just going to look at this one, piece of the process and say, where's the waste here? We're going to look at the whole thing. So we're going to think the goal is from the time that you referred to us, the goal is viral load suppression. Instead of the task is, okay, we got to do a really good intake, and then we're going to get you to transportation and make sure you have a way to get to the clinic once we've done our intake. And then we're going to do a really good medical visit. And then we're going to follow up and do really good adherence support afterwards. Because the problems with flow aren't probably, there may be some that are happening within these cylinders, but probably a lot of times it's actually happening in these arrow points between the cylinders. So we want to think, how do we get you virally suppressed as soon as possible, instead of how do we get you to the clinic as soon as possible, and maybe, there's no provider ready to see you there when we get you there. So we like, this is a really important, we don't want to optimize subsystems. We don't want to do something that's going to make our transportation better if we don't have doctors that are going to be able to see you. So thinking outside of those silos and thinking system-wide. We tend to see more impact when we work at things upstream. So instead of focusing on adherence support, we want to focus all the way from the intake, transportation, medical visit, adherence support, all of it. If we can get it right up here, instead of starting at the end here, and there's all these problems, and our adherence support intervention is really good. All five people who did it, went through it and are virally suppressed. But if you can't get them into the clinic, you're having trouble making those connections, they're never going to show up down here. So thinking about flow along the whole chain. So I've just said, how do we find waste, right? So this is one of there's kind of two things that constrain flow. They fall into two buckets. And the big one is waste. And there's previous, if you go on Target Center, you can probably search lean waste. And there's a previous one that would be helpful to kind of understanding this a little bit more. We're just going to cover it quickly today. But lean focuses on the banishing of waste as a means to value creation. And so there are 8 wastes: overproduction, transportation, excess inventory, waiting, defects, rework, motion, and wasted human potential. And those are basically, this is the order they go into. That, hey, if we, if we do too many visits than we're equipped to do, we have to move people around, we have more patients waiting than we can handle, that then we're more likely to make mistakes. Mistakes mean we have to run tests again, potentially. We're doing more motion, more running around looking for the supplies we need, because at this point we're in panic mode, and being in panic mode wastes human potential. Folks aren't working at the top of their license when they're firefighting. Folks aren't doing the best they can do if they're redoing things, the mistakes that happened, further up along the line. And then the next is, and so that's kind of, a wasteful process. So I think about this bucket leaking, that all this like good potential is just being wasted because we have a leaky process. The next type of waste I think of is unevenness. So the workload is not equally distributed. So if you have, 10 case managers and they're all feeding to one provider on a particular day, that of course the case manager is going to be able to work through their workflow a lot quicker. And then it's going to all back up when we get to the provider. And the last one is overburden. And that's just the workflow exceeds the dedicated resources. That, some days, and I know probably all of us, especially in the last couple of years, have had a moment where we felt like this poor donkey here, and just the amount of work we had to do. Like, it's wasteful because we can't even get our feet on the ground to get going at that point. So these are the main, actually, these are all the lean wastes. And then the next type of constraint to value is this idea of gaps in value. So that's what constrains flow. So if the completion of the process they have a virally suppressed, thinking about where bottlenecks are, thinking about the gap between the support a patient needs and the support they receive. So this right here is like kind of using an experience-based co-design model. So knowing what that patient needs, we have to know what value looks like to them to help them meet their goals. And if we have a mismatch there, you know, that's another place where our flow can be interrupted. Any questions at this point? All right, not seeing any. So I'll move forward. And just a reminder, feel free to raise your hand, drop questions in the chat. It's a lot of dense material this afternoon. So are you ready to see the idea of flow in action? I know we've been talking about it. So using our quality improvement tools, using our data collection, charts and graphs, we can visualize flow. And there are ways, like basically think about showing movement. It could be logical sequences, it could be process steps, it could be geographical locations, you know, the flow from clinic flow. Like it could be, you know, how they're moving through the physical clinic space. It could be the speed at which they go from, you know, in the front door to check out. And there's some graphs and charts I'm going to show you here. These are the common ones. We're not going to go through how to make these, but I think they're show you how you can use them to visualize flow. So this is called a Sankey diagram, and it shows flow across the system. This one specifically is looking at clients in an EIS program. So where did they come from, and where did they go after that? And it could be something that is useful, you know, as we do our planning. So what is that flow of new patients through an EIS program? And so they either tested positive through the EIS program, they're a re-engaged client, they were a new test to the CBO that was referred, new test referral, new test internal, retained client, new test from surveillance. So they came from the health department. And then like thinking, okay, what's that first touch point of service for them? And, you know, for a lot of them, it's outpatient medical care, medical, non-medical case management, a few others we see. And so just kind of like seeing that patient flow, then might help us know what the needs of our patient are. What are those urgent needs? And as we work through our, you know, perfecting that referral process, what are some things we need to keep in mind? Who are the key partners we need at the table? So this next one is pretty different. And this is looking at the flow of tasks in a project. And so this one you can see, this is a stacked area chart, it's called, and it's all these data stacked upon each other. And you can see this is looking at back in January, we have a lot of work that wasn't even started, a big piece of it that was ready to start, but no one was working on it. You know, not that much back in January here, work that was actually being worked on, some work waiting, some work in review, and pretty much nothing done at the start. And we see the flow of how these tasks get done. So we go from not started, ready to start, working, waiting, you know, some things need extra review, maybe had to pass the review process again, until they were all done here in July, we're like almost done. So this could be helpful, you know, if you're working on a QI project and just knowing what that flow of deliverables is. How long does it take us to get things done, to collect the data, to do the tests of change? So you kind of get this visual story and see, you know, when things get hung up. And so like it looks here that, you know, in April we were super productive. There was not a lot waiting. We were getting a lot done. And, you know, back here in January, it might have been getting started was a little bit of a hurdle. So this is one of my favorite charts for looking at flow, a funnel chart. And this really helps you see a linear process in sequential connected steps. And, you know, we can see really clearly here where the flow bottlenecks, and that's at retention. So, you know, everyone that tests positive, okay, we know that they're diagnosed. We're doing a pretty good job at linkage, 91%. And then we see, oh, retention, we don't do so great at. And some folks, you know, especially they may be suppressed, but they don't come in for those medical visits right like they should with the measures. And that's where our constraint is in retention. So that might be where we want to focus. And so you can look at, you know, anything in this funnel chart, but it helps seeing where those problems in flow might be. You know, where do we get a little hung up? Any questions on seeing this? Can you kind of see the bottlenecks in each of these? So the next step, we're going to say, how do we, okay, now I know what flow is. I know what it looks like. How do I start assessing flow in the improvement project I'm working on? So the first step before we even map that process is we want to walk that process. And the methodology or strategy that we use to walk the process is called going to the Gemba, or a Gemba walk. And Gemba is a lean word that's borrowed from Japanese that just means going to the real place, or the actual place. So we want to see the actual work happen, where it actually happens with actual patients. It's kind of the who, what, when, why, and where and how. And so there are 3 steps to a Gemba walk, and that's go see, ask why, and show respect. Those are the 3 things we want to do before we map the process. We want to actually tour that process with the eyes of our patients and clients. So we're going to go to where the work happens. We're going to be observant. We're going to observe some things under daily circumstances. This isn't meant to be, you know, a quality improvement team or leader spying on the folks in the process. It's really meant to be done just to kind of see how things are going, and to make it feel less like a site visit and more like a quality improvement activity. We're going to ask why. We're going to get a deeper understanding of why folks are doing things the way they are. And the most important thing to making it not feel like a site visit or spying is showing respect. So the QI leaders are coming in to learn from the experts in the process. That the people on the front lines are the ones who know this better than anyone, and we're here to help them. We want to hear about their problems, what they notice is constraining flow. We really want to, you know, emphasize that this is an opportunity to recognize great work. So we're not here to like get you and gotcha and why are you doing this and why don't you try this differently? We're not even talking about solutions or doing anything different at this point. We're here to just watch and observe, collect data, and recognize excellent work happening. So if we see something really good happening, we want to make note of that, because that might be a solution that could be standardized or systematized. So the next step is go see. And for the go see step, these are just kind of, I'm not going to go through each of these one by one, but just things we want to maybe have on a checklist as we go through a Gemba walk. So, you know, looking at how resources are used. We want to see, are things seem like they're flowing well? Do we notice a lot of people waiting? Do we notice, you know, patients and customers and consumers, are they being helped right away? You know, what's their experience? And it's okay to like talk to a patient and say like, hey, you know, how's it going? So getting a little bit of feedback in real time, learning from the experts in the field, and recognizing a job well done. And so if you're more familiar with the model of improvement, like this is really in still our planning phase. So like, what are we trying to achieve? So after we go see, we're gonna as we're going and seeing, we're gonna ask why. Is anyone familiar with that 5 why root cause analysis technique? Just put your hands up or put yes in the chat. Yeah, okay, I see some thumbs up. So the idea here is that you're using that same technique, that you're not here to observe, to assign root cause, you're just here to observe, and you're gonna ask why. You know, if you see something that looks like it could be an opportunity for improvement, you say, hey, why does that happen? How often does that happen? And well, why does that happen? And just ask why a couple times. The goal isn't to be annoying here. It's more so to just start understanding a little bit better. And we're going to look at alignment between process and people. Because I know I've worked with some improvement teams that are like, oh yeah, we already mapped that process. Like it's already an SOP. But then when you find out, when you actually walk the process, that like people aren't even aware that that SOP ever happened. They're never shown it, never trained on it. And just making sure people are engaged and they have the resources that they need. And I see a comment in the chat, a couple, sorry, I'm behind. So Jennifer saying, how do you select the tool to visualize flow? So that's a good question. We'll address that in a little bit. I will come back to that. And Another question here. COVID restrictions have made it harder to go visit in person and patient in contact. How would I convince my management that it's worth it? Yeah, so it's the proposition of the what's in it for the goal of that improvement project. And so it may be hard. I've been thinking about this a lot. So we do an advanced learning lab, and the idea of a virtual Gemba walk, and they're kind of hard to wrap the head around, right? So like, if I was gonna do one, I've done one for telehealth visits where I like basically you pretend to be a patient and you kind of observe things from that angle, but you can't see what's in everyone's physical space. And if the MA has 5 windows open, like those are things, it's a lot harder to do virtually. So I think that is one argument against this, a lot of the restrictions that we've had in place. So we're going to ask why, what, how, and where to grasp the situation, and we're going to ask why later to understand the cause. And last, and definitely most important, is showing respect. One of my favorite things about the lean methodology is that just the focus that quality is respect for people, and thinking about it in terms of kind of these 2 pillars, right? So quality and respect need to be equal. So if we're going to make people have goals, we need to train them on what those goals are. If we're going to hold them to measurable success, we need to challenge them and say, hey, you have the ability to do this. If we want them to solve problems, bring me solutions, not problems, we got to empower them. We got to make sure that they have the ability to say, hey, I want to do a PDSA, and just jump to it instead of going through a bunch of hoops. And if we're asking people to be, high achievers, we need to recognize them when they do achieve. So all those things contribute to this idea of a high culture of high quality. And so as we're doing our Gemba walk, we want to talk to them, hey, we were here to eliminate that disrespect towards workers through that overburden and imbalance that we talked about earlier. And then customers, patients, clients, anything that's a variation from high quality service is disrespectful to them. And so really one cannot like stand up without the other. We can't just say, oh, we're gonna be really data driven and really focus on achievement and problem solving without doing these things on the respect side, because otherwise these columns won't stand up if they're really uneven. And I see another comment in the chat. Someone I know did one recently, and they received feedback from the staff. They felt like their feedback was valued when they were engaged during the walk. Awesome. Carlene, would you want to take yourself off mute and share a little bit more?
Hi, sure. A few of us are working on some quality improvement projects at my agency. I'm with Montecure in the Bronx, and one of my colleagues mentioned that their staff was really, really pleased with, I guess, the quality and respect they were given during the walk, and they were so appreciative of being heard about what the concerns were. So I guess there was a lot of time taken during the walk, not to make them feel criticized when there were questions about things they understood. They were just being engaged to understand the process, how to improve that process. And as a result, we actually implemented, that department implemented a permanent change. Now they're including frontline staff in their quality improvement meetings. So it was great.
That's fantastic. And that is exactly why we take the effort to do this type of thing. Especially if you have staff that may be burned out on quality, and they feel like, that they're asked to do these, like it's like another duty assigned. It really shows the value, and it shows that that you are a partner, and the solutions come from the people who do the work. So that's fantastic. It's awesome that I always get excited when I hear folks are already doing these things. So there's a quick little checklist I have. If you want to try this out, it's really simple as, getting yourself a stopwatch, getting yourself, either a notepad to jot things down or a tablet, using some templates and things. And you just go through and, capture times of steps, of processes, anytime you find yourself waiting, total time start to end. Those real rudimentary metrics we're going to talk about in a few minutes here. Will be super helpful as we kind of dig in deeper. to where the problems in flow are. We want to pay attention to flow coming into the process, especially for staff, consumers. So like we want to know like what, basically when the process starts, like what are we already on the hook for, right? So it's really helpful like working across silos when the problem might be even further upstream than the process we think we need to improve. Again, thinking system-wide to create value and banish waste. We don't want to optimize one step in the process. We want to make the whole thing valuable. So start thinking, observe it first, but as soon as you kind of get done with that walk, then your brain mode kind of switches. You start thinking critically about what needs to be done as a result of what you see. And I think to get people on board with this is you got to say like, hey, we're going to walk through, but with the problems that you share with us, we're going to help you address them. So think about what you'll look forward to the next Gemba walk in response to the current one. So again, as I talked about in the top of the presentation, those different process map states, it might be worth it to rewalk the Gemba every time you do a change, right? So every time we remap the process, we want to walk the Gemba. And last but not least, what as a quality leader can you do to help? If there is some like really low-hanging fruit there, don't be afraid to offer help. And again, so don't optimize subsystems, prioritize the improvements based on what you see, and respect people and help make their lives a little easier. So this is a worksheet that I've used with a couple of teams, and I know the slide's probably not easiest to see, but just looking at the description, the process step, what number it is, so it correlates to a process map that's either going to be developed or already has been developed. The observer is kind of looking at, is it a value add, non-value add? Is it something that's essential, something that's a requirement? Looking at the cycle time for each step, observation date, any voice of the customer, if they talk to any clients or consumers along the way, what do they have to say? Just jotting down some notes. Over here is just those steps that just kind of like, this is just like some of those checklist steps to take any notes. And then last but not least, this third section over here is more like a debrief afterwards. So once we've filled up this template, looking at comments from staff and patients, any pain points or wastes we noticed, any delighters or values, anything we need more input on, next steps, potential improvements. So then really to kick off that brainstorming in response to what we've seen. So now that we've walked the Gemba and we have all these notes, how do we actually map the flow? Yeah, absolutely. I can, I don't know what the easiest way to share that. I don't know if the slides, did they get a copy of the slides, Shay? Is there a way for them to get the slides? It's in the slides. Yes, you can have a copy. We'll figure out the logistics. Because I think everyone registered, so we have all your emails. So I think the basic way to start looking at flow is using a flow chart. So the value of a flow chart helps us determine what's going on. Do we agree on the process? Where are the delays? What are the next steps? How do we improve the process? So we get the mutual understanding. We get the examination of a process efficiency, of flow, of missing data. It shows us over complexity, redundancy, unnecessary loops, needs for standardization, how processes and systems fit together. And it's comparing, again, we're doing them in each state, we're doing them, and we're looking at the flow in each process state. It can help us it's really powerful to use in conjunction with other basic QI tools. So those little times that I said, write down, we can use those to populate our run charts. We can find drivers, and so maybe I want to do a driver diagram. Maybe I'll see some root causes and I'll do a fishbone. So like to me, this is that first tool to really gets everything else going. So I have commonly used flowchart symbols. There are more, and I think it really depends on what you and your team is most comfortable with. I have teams that I work with that all they need are these four symbols, and that's a great way to get started. And maybe you want to start bringing in documents and inputs of data and then databases they go into next. And so like then all of a sudden you have the people moving and then the flow of data in a process map. So then you're making it another whole nother level, a little bit more complex. I really like delay. This is one, and those wait times, and I actually put in the step like how long the delay is in my flowchart. This merge one is really helpful. I've been working with some teams on Rapid Start, and it's like a lot of things coming from different angles. And when you have decision points and then they merge, that's a place where bottlenecks can happen, as we'll see. So I like the merge symbol. Connector to other process. That's when you start getting fancy. And I'm not even going to map this. We don't want to keep these maps too big. So if you're going to connect it to another process, sometimes it's just easier to use a circle and say, see other map. This isn't, in the scope of our improvement project, but this is where people go. Great. Yeah, Visio has some templates. Visio, Miro, those are two tools that are commonly used. If you have a Visio license, like that's kind of I think the one that folks are most familiar with. Miro has a pretty robust free version. I recommend that one. So I just said how great flowcharts are and all the cool things we can do with them. They do have some limitations. So you don't want to draw them too complex, because then we're just like, we're just overdoing it, right? The ultimate goal shouldn't be, oh, draw IO. Yeah, that's another one I really like as well. We don't want to overdo it. The goal is to improve health outcomes, patient care, and client satisfaction, not to create the coolest flowchart we can. So you can burn people out if you make them too big. We want to have that multidisciplinary and including people with HIV involved in the creation, because where ultimately we want to go to is improving flow and creating value. So we want to have that perspective in there. And they're fantastic for seeing a process, but they don't always limit themselves for quantitative analysis alone. And so I say, like, start by capturing some of the times and things, just jotting them down in the margins of your flowcharts. That's a good way to start. And then next time when we talk about value stream mapping, you'll see the concept of how we bring a little bit more quantitative data into process mapping. And thank you for everyone throwing in, yeah, what's your favorite tool for using flowcharts? Keep those in the chat. Keep them coming. All right. So is everyone ready to look at a few examples of flowcharts? Great. So it's getting close to dinner time. I'm getting hungry. Who wants to make a pizza? So here we see two examples of flowcharts of making pizza, and they're extremely different. So this one right here, it's like a pizza protocol, right? There's no decisions, there's no complexities. It's just like very much, this is the way we make pizza, right? Like follow these steps, follow this recipe. And then on the right here, definitely not as complex here. It's, hey, I'm going to decide to order pizza. I'm going to order delivery. If they don't have delivery, you're eliminated, right? So I'm going to place that order online. I'm going to wait for it. I'm going to pick it up at the door. I'm going to eat. So not a lot of active thing from the point of the customer here. Not a lot of stuff happening on the back end. So two very different ways to look at the same process. So this is my last one example of pizza here. This is my process for making pizza, and you can see all the different steps here. As we kind of go through, I'm gathering the ingredients. Don't have them? Well, then I need to buy them. Are the toppings ready? Well, no. If they're not ready, then I gotta chop them and wash them, and get them ready to go. And then you see I have more flow once I get to rolling it out, and at this point I'm pretty much going. So it takes almost 2.5 hours from when I decide I'm ready to make this pizza until it's made. And so if I was going to optimize the bottlenecks and delays, so we're looking at this map, I'll give everyone a few minutes to look at it. I kind of made it into a swim lane map of sorts. I started breaking it down by phase. So this would be the first thing I'm doing when I have a process map is, okay, there's the planning, the shopping, the prep, the assembly, the baking, and then the finishing and serving. So given what we've just learned about flow, where do we see any obstructed flow? in this process map. Yeah, Carlene got it. So shopping time. That's, look at the size of this. There's only a few steps and it takes a whole hour. So almost half the time is on these other process and then another step. So that's really constrained. If I did my shopping ahead of time upstream, then when it comes to this process of making it, I've already cut out a lot of the time. I was working with another team just this week and we were doing this example and the preheat the oven, having it up here instead of, okay, I've prepped all the toppings and then I remember to preheat the oven. So making sure that's in sequence. You could have decision points here where, you're checking and, keep opening the oven. Well, now I'm just slowing it down because the oven temperature is dropping every time I'm opening. So a fun little example, but I just like using that, something we're all familiar with before I get into the HIC specific examples here. So yes, this, what I just spent talking about making pizza, it does apply. So Jennifer, yeah, this would be store-bought dough here. If I was making dough from scratch and maybe I'm doing a sourdough, right? And I've got to ferment the starter, right? There's all these kind of complexities of the dough rising. So moving to HIV specific examples, I know this is a little tough to see here. I'll zoom in here. But this was a process I was working on with basically a handoff from an EIS client to case management. And so this is a status neutral approach. And you see all these things that happen that, that can impede the flow. So it's not just, okay, if they're negative, then we got to do all these steps before we get back to kind of what was in the original process that we originally had. So you see, anytime that there's a decision point, we had some kind of areas where it really threw us off our flow. And then the other thing to keep in mind that I like to highlight here was this team. We had some question marks where there wasn't it wasn't clear when we walked the Gemba. One time it was a case manager doing it, another time it was a peer worker. And so it wasn't standardized of who's making the phone calls. It was kind of whoever's available. And we said, that's probably not, thinking about that respect for people. If I don't know I'm going to be on the hook for making phone calls, or, I'm just hey, you need to do this. That we need to standardize this process a little bit more. The other big question we came to, and I'm sure as others you struggle, is what if you don't get those documents you need, federally household income and things like that? What comes next? Is it one day we called 3 times and then sent a letter, the other time we sent an outreach worker? That there was some lack of standardization. That this really holds up the flow because this is one of those requirements. We have to make sure you're eligible before we can complete your intake, right? So here's another process looking at intake for a new HIV diagnosis. And we see some wait times here. And again, is the client available? No, well, then we have to schedule the intake. So that's impeding our flow. But that's all right, because if the client's not ready, we don't want to push them. Okay? We want it to be pulled. So then we have here, is a medical appointment available when the client is available? So if this client's hey, I get off at work at 4, so the earliest I can get to the clinic is 4:30, and your last slot is 4:45, then you're already, we got to maybe do some reconfiguring with some open access in the schedule to get this person in. And they may have to wait a little bit longer than they would otherwise. So we try and start folks within 7 days. Maybe that doesn't happen because we have such a limited availability.
2 hours.
Great. Was that a comment in the chat or comment? Sorry. No, okay. So then we have consent and eligibility. We got a review point. I mean, what stands out to me in this is all these decision points back to back to back, right? And anytime that, depending on what happens, we're kind of splitting out our flow and then we're bringing it back together to another decision point, that there's a lot of opportunities for waiting just in this little piece. So the next step is you've got your process, you've walked it, you've mapped it, you've sat with a team, and you are ready to go. So how do we start quantifying? How do we start really seeing? How do I systematically, if I have a good map I'm happy with, how do I start using it for improvement? to address some constraints of flow. So every system has a constraint. No matter how good your process is, it always has, when I say constraint, it could be challenges, it could be, hurdles, but thinking about it as the slowest step. Even if I have a really good process with continuous flow, I still have something that's the slowest that I could get better at. And so these are the things we want to look for when we're doing improvement with a lean methodology, is starting with that biggest problem, right? Because if we try and fix something that happens after the problem, we could actually make things worse. And I'll share you an example here. So a program was working and they were having folks work overtime, right? And so what they were doing is they were just throwing more throughput into a system that wasn't designed to handle it. And so it was a quick fix, like, yes, we can have people work overtime and then we can address these constraints of flow temporarily. But what they didn't realize is they were burning people out. It's not sustainable because it's really expensive. And that it led to instability and people feeling tired and burned out and turnover. So we can address it short term, but long term, we're not doing ourselves any favors. So getting back to the earlier question about how different ways we can visualize flow. So one of them, this is actually like a control chart, is really good if we have longitudinal data, so data over a longer period of time. And this actually isn't a control chart because this is only looking at one standard deviation instead of 3. So this is actually a run chart. But like looking at, putting the more data savviness we have, that would also be another way that I would decide to look at things. I like funnel charts. That's really easy and really good. It doesn't require a lot of math. And then as you get more sophisticated, run charts, control charts, and you can start seeing, the steps that are our biggest constraints. So thinking about our process, like, and looking for those constraints, we start with this capability, right? So think of this letter P is all the resources we start out with. And then we move it to the next step and we lose some of that capacity. We don't have as much capacity in the next step as we did the first. And it kind of keeps going. And then it gets to a point where this is our slowest step. This is the place where flow is most constrained. And so even if we have the ability to see 5 patients in case management, if they go to the after they go to the doctor, and the doctor can only see 3, we've already slowed them up, right? So nothing will ever be able to work faster than this slowest step. So even if this last step is checkout and I can breeze people out and check out through 2 minutes, it's never going to get to that because it's always going to be constrained by waiting to see the provider at step C here. I know that's kind of confusing, but does that make sense? This is a really high level concept. This is, I think, the most advances we're going to get in our time together. Any questions on that? Thank you, Jacqueline. I'm glad the slide is helpful. Great, makes sense. So we're going to look at this example right here. So this is a linkage example and data to care. And so I don't know if it can really, so I'll share they had a problem here, like patient consent to receiving services, right? That's a barrier, that's a constraint. But there's not a lot we can do about it. If the patient doesn't consent, we're probably not going to use our a lot, or at least not at first. We're not going to use a lot of our improvement resources trying to convince them otherwise. We may say we're going to follow up in 24, 72 hours, whatever, try and get them to reconsider. Giving them the information to know the door is open later. There is an issue here with the decision of when a patient is truly out of care or not. Are they just out of care from what we can see in our surveillance system and our Ryan White system? And there might take a little bit of a time to refer them to that linkage coordinator. There's a lag that our flow is being constrained between this extra step of making sure they meet the definition of out of care and referring them to the health department. But by far the biggest opportunity here in this example was once we find out the case manager has the list, they're looking at, is the contact successful? Yes. So we know these are people that we can get them on the line. Placing that referral is actually the biggest constraint. So the process measure was the number of referrals to the CHW, and only 34 of 76 referrals. We were able to contact them, but getting that referral placed was the constraint. So this is where we want to start, because if we can't place the referral, we can't contact them, we can't determine their adherence status, we can't find out what barriers they have and how to address them, we can't link them to care. So it really starts with getting this referral. So that is the biggest constraint. And so we're not looking at, looking at a smaller step than linkage. We need to start looking at referrals, and that's what's impeding our flow. So I'm going to walk through this like step by step. And if you're working on a QI project right now and you have a flowchart, like this is how I would, as a QI coach, would come in and start looking at it. So I would start and I would look at each activity symbol. And I would say, what is the value cost to the patient client to do each step? How much time is it taking them? What forms do they have what hoops do they have to jump through? What forms do they have to bring in? And that's the very first thing. I would go through each and every activity step and ask those questions. And then so after I've done that, I would go to a decision point. And then I already said, like, oh, you notice flow sometimes gets impeded around decision points. So once we've gone through every action step, I would say, are the decisions necessary? Are they redundant? Are there back-to-back decisions? And that's when we have those merges, those bottlenecks, and what additional outputs are generated by a decision. So if I go left or right, what extra data entry, what extra forms, what extra time, what extra processing is involved. So that's the second thing I would look at. And then the next is the choke points here. And this is, I said that merge symbol is useful. Like we have all these different yes, no's, and they're all converging on this one for whoever this is, looks like the med assistant, that they're just getting a ton of workflow dumped on them at once. And so we call it these choke points, a bottleneck. And you can see, I mean, it literally is, it'll stand right out on your flowchart. You'll see the bottleneck, why it's called the bottleneck, because we have all this process merging here on this one step. So what are the delays? What are the cause? Is it asking people, especially if you have a flowchart and you see a step where this is happening, talk to that person and say, like, how do you feel? What ticks you off? Why do you think this is happening? And this is a great place to start addressing those issues in flow. So the next thing I would look at is rework. And so my rework loop here is happening here. So they're coming into this choke point, they're going through, they're waiting, they're going through, they're filling out forms, some data is being entered, there's a decision. And if this decision ends up being a no, they're getting thrown back into the queue, doing another step, doing more waiting, going through again. So that could be, I didn't bring the right form. Oh, no. Well, I go and I get that form. I do more waiting because I can't get right back in. And I go back through the steps I've already been through. So like anytime you see a rework loop, like that's something that's impeding flow, and you really want to address that. There's a time, there's a cost, it aggravates patients, it aggravates staff. These are definite things you want to look at. So after I've done the rework loops, and so if I've gotten through like 1 is pretty helpful in general, and then 2 through 5 are like ones that are you really want to calculate out. So even if I have a process with pretty good flow, where I want to start looking is number 5, and that's our handoffs. And so anytime it goes from case manager to medical assistant, it could potentially go back. I want to talk about how the handoff is. Is it smooth? Is the patient is it really a handoff and not just a wait there? And is it a warm handoff? Are they feeling anchored into that next step, or is it just kind of go wait over there, and when the next person comes, you'll know? So looking at teamwork, at standardization of those handoffs and efficiency. So when I've done handoffs, I'm going to look at delays. These delays, why is there delay? What's causing it? How long is it? Is it in line with what the patient or client is willing to wait? Does it impact their experience? Can it be reduced or eliminated? So those are what I'd be asking about delays. And like I said, go ahead and write, if you have these, you're using a flowchart with this symbol, write that delay right in there. Put that time, 14 minutes, 20 minutes, whatever it is, right in there. So then after I've looked at delays, I might start looking at, and this is like the more nitpicky stuff, documents and forms. Are they needed? What is the cost versus value? Are they manual or retyped? Can they be done ahead of time? You know, that filling out a form on paper and then giving it to front desk to type into the EMR versus can I have a kiosk and the patient could just type their information in once and we only ask questions if something doesn't look right or doesn't fit our standardized data. And then so this idea of using a flowchart to not just capture that patient flow and that staff flow, but that flow of data. How do we go from form to database? And does it have to go into one database versus two? Who's putting it into that database? Is it timely? Is it right? And hey, can we use this data for improvement? And so that's how I would, as a QI coach, break down a flowchart. So again, this is a preview for part 2. So we kind of talked through what the idea of flow is, how to look at it, how to visualize it, how to map it, how to walk that process and have the input that's going to help us make a more detailed flowchart like this. And then in part 2, what we're going to start moving to is the idea of how do we capture some more quantitative data, some of those numbers other than maybe just writing in the minutes. How do we start capturing qualitative data like value? And I might start with a flowchart here and I'd say, oh yeah, we should axe this step. No one likes this. These decisions are unnecessary. Can we get these ahead of time further upstream? Patients really like this. This is really important, but there's a bottleneck here. How do we fix that? This whole rework loop, we got to get rid of that. This delay, can we reduce that? This one, we can't really do much about because it's coming out of this bottleneck. They love seeing their provider that they're getting, patient-centered care. So we want to see that there are any strategies we can make sure are happening and some of these other steps where they don't feel like it's as patient-centered. And then so we're going to move from kind of this flowchart with all this markup and data and times and things to the idea of a value stream. And that's really where we're going to pick up in part 2 next month. So at this point, we have a good amount of time for questions. I'm also going to type one other thing I want to share here in the chat. There's this really good, so like flow, like I've broken it down in a lot of technical QI terms today. But there's also the idea of like kind of like the psychology of flow in our personal lives. And there's this really fantastic TED talk that if I'm like trying to maybe engage frontline staff and a presentation like today might be a lot for them. I would show them this TED talk first and the idea of like flow in your personal lives. And like he has an example in there like why we like to binge Netflix, because it's that idea of flow. It's that I don't have to do anything. I don't have to click. It's just like that idea of pull, right? They're pulling me in. It's just the credits roll and then the next episode starts. And just how we can use flow in our personal life to stay motivated and have that kind of in the zone feel. So I think that's a good argument for that. Flow is on the personal level first and then moving it into the technical quality improvement sense. All right. Any questions? Oh, I see. Oh, I just saw one I missed here. I was doing a flowchart last week with a provider and they kept jumping to solutions rather than walking me through what they're actually doing. How can we respectfully refocus that? Excellent question. Excellent question. So I talked a little bit about this in the respect for people section where, I understand why folks want to jump to solutions because I think we want to solve problems, right? And, how to respectfully do it. You can kind of point back to the methodology, that may or may not resonate to them like, hey, we want to define the problem. We want to make sure we're looking at this from all angles. We want to make sure that we have the best solution, that this is a great solution. Thank you for that. But, we want to make sure that we've kind of looked at this from all angles. And is that helpful at all? I mean, how persistent were they? You can take yourself off mute. If you can share any other details, I can kind of help.
I think they also came in with assumptions that I knew everything. And I had to sort of, okay, wait, stop. The patient walks in. What happens? And it was hard to take them back to that. It worked eventually, but I was just wanted to hear from you, like, what's the best way? Because I'm also getting to know them. I'm new, and you know, I wanna hear what they have to say, but also, like, if they jump to the end, I'm not gonna be helpful at all. So it's helpful what you said. It's like validating their suggestions, but then like slowly shifting it back to just let's start from the beginning. Yeah.
That context is helpful. And so I'm going to give you a suggestion that is it's super helpful. To say, hey, thanks. You know, like that's a really good suggestion. Hey, have you seen the data, or show me the data, or turning it back to data, both quantitative data, you know, outcomes and process and things like that, and then also the experience. Like, oh, you know, like that's really helpful experiential data. Have you talked to anyone else about this? Did they share those concerns? Anytime like you say, show me the data, then you're kind of putting the brakes in a gentle and also I think a smart way, a really reflective way, to instead of just going with the first solution that someone has and say, yeah, I know I'm right. This is the answer. Oh, that's great. That's super helpful. Like, let's look at the data, right? Because sometimes they don't have it. And most times, actually, they don't have it. Great question. Any other questions? Great. I'm just going back to the chat. I'm sorry I missed some of your comments in the chat. Yeah, the burnout is like that's like the number one thing that I think is it makes quality improvement tough, when it just feels like it's not addressing the needs of our staff and patients. And, you know, we're just working urgently instead of, you know, intelligently. Awesome. Thank you so much for that comment. Yeah, like I love hearing about the quality improvement converts. All right, so if there are no further questions, I believe Shay has the evaluation poll. It's real quick. I think this is something that was a flow improvement project, that the survey used to be a lot longer and they streamlined it, made it a lot quicker based on some qualitative and quantitative feedback. So please do fill out the poll. We really appreciate your feedback. It helps us determine you know, the relevancy of the webinars we do, what we can do differently next time. Great. Awesome. Well, thank you for your feedback. And if you have any last questions, you know, please let me know. I'm here to chat for a little bit longer. And if not, it was great seeing you. Thank you for your time and attention. And I hope to see you back for part 2.